Good evening, ladies and gentlemen, and welcome to the Baker Institute. As you all so painfully know, we are still in the silly season, the time when presidential candidates have been known to engage in rampant political posturing and hyperbole to attract media attention, raise campaign funds, and of course, get votes. So I'm sure that we will continue to see cartoons like this one that I'm showing for weeks to come. The humor of these cartoons masks an electorate which has become deeply divided. The Pew Research Center's 2012 Values Survey, I don't know how well you can see this, reports that the political values gap is wider than ever. You can see the categories: scope of government, the Obama voters on the left-hand side, the Romney voters on the right-hand side, and the green in the middle of the swing voters. Second category, labor attitudes, environmentalism, social safety net, business attitudes, immigration attitudes, efficacy and fatalism, national security, social conservationism, religion, government responsiveness, national optimism, personal finances, political engagement. They narrow in the bottom, but you could see on the top how deep the divides are. The survey asked people whether they agree or disagree with statements such as government regulation of business usually does more harm than good. On this question, 76% of Republican respondents agreed, while only 41% of Democrats did. The slide you are viewing now shows you an aggregate summary of the Pew survey's results, classified according to respondents' intended choice for president. The Pew survey finds that Republicans and Democrats were not always this divided. The slide I'm showing you now indicates that the disagreements on a range of opinions regarding our country have more than doubled over the 25 years when the survey has been conducted. So we're in a much more polarized environment today politically than we were 25 years ago. Tonight's event is a step away from partisan politics and an effort to objectively examine the platforms of our two presidential candidates. With our Baker Institute series, Election 2012 Policy Perspectives, we seek to provide a nonpartisan forum for discussion and debate of the key issues in this year's presidential race. Tonight, we're starting our series with a discussion of healthcare policy. We invite you to join us again on Monday evening, October 8th, for a discussion of jobs and the economy, led by Baker Institute Fellows John Diamond and Russell Green. I also invite you to visit our website to view Election 2012 Policy Perspectives. Here you will find news stories, publications, and events related to the elections that feature Baker Institute Fellows and scholars and their views and analyses. Now I would like to introduce you to this evening's speakers. Vivian Ho is the James A. Baker III Institute Chair in Health Economics at Rice University and a professor in the Department of Medicine at Baylor College of Medicine. Her research examines the effects of economic incentives and regulations on the quality and costs of health care. Dr. Ho's research is widely published in both economics and medical journals. Her research has been funded by several organizations, including the NIH, the National Institutes of Health, and the American Cancer Society. Dr. Ho will be speaking tonight on the healthcare platforms of President Barack Obama and presidential nominee Mitt Romney. Elena M. Marks is a Baker Institute scholar in health policy. She is an attorney and currently works as a consultant to the healthcare industry. From 2004 through 2009, Elena served as the Director of Health and Environmental Policy for the City of Houston. She has been working with the Baker Institute to study the adoption of information technology in the healthcare sector and to follow healthcare reform at the state and local levels. Ms. Marks will be speaking tonight on the future of Medicaid in Texas under a Democratic and Republican administration. Now it's my pleasure, I would like to introduce the moderator for this evening's event, Dr. John Mendelson, who is the L.E. and Virginia Simmons Fellow in Health and Technology Policy at the Baker Institute. His work focuses on the identification and evaluation of new health technologies, therapeutics, and best practices, as well as the promotion of policy recommendations to improve national and global health outcomes. As you all know, here in the community, until September 2011, John served with great distinction as president of the University of Texas's MD Anderson Cancer Center here in our city. He remains on the MD Anderson faculty as co-director of the Sheikh Khalifa bin Zayed Nahyan Institute for Personalized Cancer Therapy. John has received many awards: the Fulbright Lifetime Achievement Medal, the Dan David Prize in Cancer Therapy, the Gruber Memorial Cancer Research Award, and the Lifetime Achievement Award from the 10th International Workshop on Molecular Target Therapy of Cancer. So join me in welcoming John, our moderator, and our speakers to the Baker Institute podium. Thank you.
Thank you for joining us here tonight. I'm going to start off with the presidential platforms for healthcare for President Obama and Mitt Romney. So, to start with, so I wanted to start this off with the common ground that we have between the two presidential candidates regarding health care. Both candidates would allow young people to remain on their parents' health insurance plans until 26 years of age. And so that was a reform that took place with the Affordable Care Act, and Mitt Romney supports that particular decision because it does lead to lower affordable health insurance coverage for a fairly healthy population, so this doesn't lead to a lot of increased health costs. Both of them agree that there should be coverage for people with pre-existing conditions when they're trying to purchase new health insurance, but Romney does think that it should only be the case if the individual maintained coverage without a significant gap. And there's nothing in his proposals yet about the price of insurance because one wonders if people have pre-existing conditions, could the price for health insurance be quite high? Both candidates believe that we should facilitate information technology operability, that health information technology, electronic medical records are the key to the future in terms of being able to handle complex medical cases and also lower healthcare costs and improve integration of healthcare. And both of them encourage formation of insurance purchasing pools for individuals and small businesses. The key point is the last one, that both promote alternatives to fee-for-service. The problem we have, and I personally believe this, the major problem we have in terms of controlling healthcare costs in this country is our reimbursement system is set up to reward providers for performing more care, and it doesn't provide enough rewards for providing higher quality care. So I think it's extremely important to recognize that both parties and candidates strongly believe in this. Now, if we see if I can get a clicker to work here. If we go on to the next slide. There we go. So I just thought we should put in a little bit of humor before we get started on the serious matters. And this I think is certainly when I get on Facebook and I'm sort of going back and forth with the other health economists I know across the country, there are some who certainly believe that this particular cartoon or this particular illustration represents that type of concern. But let's actually look at the numbers and what we actually see under Obamacare. So really, the Affordable Care Act is about increasing insurance coverage. That is the main point under which this particular act operates, and it's the one that I think you should remember. And that change is going to occur under two different major cases I'll talk about, but you can see that there are projected increases in health insurance coverage through Medicaid and the Children's Health Insurance Program that are supposed to be large and increase over time. And the health insurance exchanges are supposed to grow rapidly. So this is the number of millions of people predicted to gain insurance coverage over time. So, so the Congressional Budget Office, which is nonpartisan, predicts that by 2022 we're going to have 25 million additional people covered with health insurance through the exchange, and I'll explain those in a minute. And that's going to lead to this estimated 30 million drop in the number of people who are going to be uninsured. There will be 30 million more people who will have health insurance coverage. Okay, so in terms of the exchanges, how are those going to work? They're state-based programs under which small businesses and certain particular individuals are going to be able to purchase insurance coverage. Not everyone is going to get access to this, okay? If you're in a Fortune 500 company and you're employed, you're probably not going to get access to a health insurance exchange. And to help people afford health insurance, which many people are not able to do right now, there are going to be premium and cost-sharing credits available to individuals and families between 133 and 400% of the federal poverty level. It's also it's available to people who are going to be self-employed, or if their employer's health insurance fails federal standards of quality or affordability that are written into the Affordable Care Act, or if they're not working, they can get access to health insurance through the exchanges. Medicaid is the other part where we're going to see this large increase in insurance coverage, and states each have their own right to choose to expand eligibility to all persons, regardless of age or gender, where their family income is below 138% of the federal poverty level, and Elena Marks is going to be talking about that in much more detail in her part of the talk. And just to give you an idea of what's the federal poverty level, it's for a family of four right now, the threshold is about $23,000. All right, so now that's the insurance portion coverage part. Now, how much is this going to cost? When we're thinking about, is this really going to hurt the federal budget? And so these are projected costs, net cost of coverage, and you can see this is over a 10-year period, and these are in billions of dollars. So Medicaid and CHIP, for example, is going to have increased its expenditures, predicted to be of $642 billion over time. The exchanges are going to be even more expensive. We're talking about $1 trillion over the course of 10 years, and you can see these small employer tax credits are quite small. There are going to be some cost offsets to this higher expenditure in terms of coverage. So some of the things you'll see, you've heard about, the Supreme Court has upheld the individual mandate to purchase, that people are going to be required to purchase health insurance. People who don't are going to be expected to pay fines, and we're expected to have $55 billion less in coverage, less in cost because of that. And you see the other numbers that are adding up. Penalty payments by employers. Employers, if they don't provide affordable health insurance to their workers, they're going to have to pay penalties as well. And there are some other effects on tax revenues and outlays, and feel free to ask about that during the question and answer period. But we are talking here, this is a very large number, over 10 years, $1.1 trillion in additional healthcare expenditures. This is the net cost of just the coverage, the insurance portion, okay? So this is not the entire bill. And let me show you what the CBO has predicted out in terms of the ultimate effect on the federal budget. Okay, so what I've showed you is this dark blue stuff on the top. This is the additional expenditures that we're going to incur because we're covering many more people with health insurance coverage. There are also going to be other changes in revenues. There are going to be changes in taxes. There's going to be increases. There's already increases in taxes on insurance companies, medical device makers, higher income people. There's even this obscure tax on some of you, if you're lucky enough to make a profit of more than $500,000 when you sell your house, you're going to pay a small tax on that excess over $500,000. Okay, and so what actually happens is there's also cuts in terms of Medicare expenditures that will go on because there will be lower payments to insurers who are covering people through Medicare Advantage. There will also be some sort of cuts in reimbursements to hospitals and other healthcare providers. Because of those cuts and those increases in revenues, actually in the end, by 2021, we're actually, the entire Affordable Care Act is predicted to actually save us money in the long run and not actually be a net increase in costs. Okay, that's what the CBO predicted. Now I want to show you something else. Okay, this is a slide made up by Douglas Holtz-Eakin, who used to be the head of the Congressional Budget Office. I remind you that it's a nonpartisan group. He's a very talented economist, and this is a slide that he put up for a conference that was organized by Health Affairs. And what he is saying is he thinks the current CBO numbers are wrong, and so that's why you've got this substantial deficits, and he puts in a lot more likely. So what he put up at the time that he gave this slide, which is before the Supreme Court made his decision, so that's why the numbers are a little bit different from what I just showed you. But he shows the official CBO score, giving savings over this 10-year period of $124 billion. That's why there's a minus. He argues that the Affordable Care Act as written would actually put us in the red, and expenditures would be greater than revenues by $554 billion. And then he goes and projects out 20 years into the future. I never like to look that far ahead. That's just too hard in terms of economic modeling, but there he goes, and the number gets quite a lot bigger. And so the question is how does he get this number? And here are all the calculations for things that he says were computed incorrectly by the CBO. And this is someone who used to run the CBO, so he is quite an intelligent person. All right? So I'd like to walk you through some of these. Okay, unachievable savings. He says we're not going to be able to get the spending cuts that CMS is supposed to implement under the Affordable Care Act, that we're not going to be able to get the cuts in the Medicare market basket updates that go to providers, that there won't be an independent payment advisory board, that Medicare Advantage interactions aren't going to work out like the law predicted, and that we're not going to be able to have this lower Part D premium subsidy for higher income beneficiaries. He thinks that Medicare beneficiaries are going to rise up and protest against that. Now, what I'd like to get across to you is I think there is some truth to some of the things he's saying, but there is also some things which have turned out to be incorrect. And so what that leaves us is we just don't know. We just don't know if this act is really going to be cost saving in the long run, or is it going to lead to some increases in costs. I think it's probably going to be somewhere in between. And so, for example, we certainly don't have the independent payment advisory board in place, and Congress was really against it and almost, I think, got it completely zeroed out in one of their last sessions. But this cut in Medicare market basket updates has already occurred for hospitals. You can look it up in the Federal Register, and any of you who are working as hospital managers know that those reimbursement rates were held down in just the last fiscal year, so that actually has gone in place. Some other things, and so there was the question of, well, what about Medicare Advantage drug premiums? We're not going to be able to achieve those savings. If you actually look, the savings went into place starting in 2011, when insurance companies were told we're freezing the maximum possible rates that you can receive, and then those premiums are slowly being adjusted down in 2012, and you can see across all different types of insurance policies that are in Medicare Advantage, which is prescription drug coverage for people involved in Medicare, those premiums have actually gone down, and they've gone down steadily from 2010 to 2012. So that actually has worked. The other thing is, would it be politically infeasible to vary Medicare premiums by your income? It turns out that this is what, if you get on the Medicare website for 2012, your Medicare Part D premium is going to vary by income. So that's in place, and that's actually been able to go by politically. And there was, concern by Douglas Holtz-Eakin that wouldn't happen, but seems to be going through just fine. Unscored budget effects. This is another issue in terms of, there were a lot of things that were introduced in the legislation, but Congress is still required to approve the funding for these particular programs, okay? So that money, though, wasn't in those budget figures that CBO calculated. So this is additional spending that could happen. And, for example, the IRS needs $7.5 billion to enforce the insurance mandate. The Center for Medicare and Medicaid Services needs money to administer all these new programs that are going on. There needs to be $50 billion for healthcare grant programs. I believe much of that, I don't have the whole breakdown, much of that money has been passed through in terms of grant programs, but there's also a substantial amount of it that actually has been held out, and Congress has not given the extra funding. And then this is the big number down here, close to $210 billion for the Medicare Physician Payment Reform Act. So those of you involved in the Texas Medical Center know that what we have is a messed up system in terms of Medicare reimbursement for physicians. We're supposed to be always sort of controlling the growth rate of those reimbursement rates, but we just always let it go every year, and there's always some panic, and everyone, you know, it's sort of, Congress has to approve some sort of adjustment each year to allow Medicare reimbursement rates for physicians to go ahead and increase. Otherwise, physicians are just going to sort of drop all their Medicare patients. So this is true. We do need to set aside this amount of money to fix this particular problem. However, I do think it's unfair to put this number as a criticism of the Affordable Care Act, because the fact of the matter is the problem is really a problem that has to do with Republicans and Democrats. This particular aspect was not actually written into the act, and it's going to exist and sit out there whether we have a Democratic president running this country or Republican. So, you know, everyone agrees it's a serious problem, but it's not necessarily something to assign to the Affordable Care Act. Other concerns Douglas Holtz-Eakin has: will a tax on Cadillac health insurance plans be politically feasible? We're going to tax very high-cost health plans out in the future, but not for a number of years. I don't know. We'll wait and see. Another good point he has, this is $53 billion, so this doesn't sort of explain the entire giant red number that he spoke to, but you know, there's supposed to be savings from higher Social Security revenue because employers are expected under the Affordable Care Act to shift spending from insurance over to wages, but he makes a point that higher wages imply higher Social Security benefit payouts in the future, and we have to account for that. Okay, so that's just a brief summary of some of the things going on in the Affordable Care Act, and now I'd like to switch over to talking about presidential nominee Mitt Romney. And so here's my cartoon I'll just let you digest that. I don't know, this one made me laugh. So this is kind of what we're referring to when we talk about Romney Care. We're actually referring, in many cases, people are talking about the health care insurance plan that Governor Romney introduced in Massachusetts, which he has had to distance himself from as part of the campaign because of other people in this party, you know, it's sort of, I won't talk about that particular issue tonight. Feel free to come back and ask me about Massachusetts health care and the question and answer. Okay, so what I did, there is less detail for Mitt Romney's plan simply because he doesn't have the full backing of an organization like the CBO or these other groups to do all of his calculations for him, okay? So there are just fewer facts out here. What I pulled off of the website and then off of sort of trusted reporters and other commentators that I've been able to find information on. So first thing, he wants to shift control from the federal government to the states. One of the main things he's going to do is block grant Medicaid and other payments to states. So what exactly does block grant mean? It means you convert the federal share of Medicaid spending the way it works, into a sort of a block grant, just a fixed amount of money, which will vary over time. You're going to index it for inflation and population growth. And this is from Paul Ryan's report, the fiscal year 2013 budget resolution, which if you look on the Romney webpage, they have adopted this. Those payments from the federal government are going to grow 1% above inflation per year in exchange for fewer rules on how states spend the money. So right now, the federal government spends much more than 1% additional per year on the Medicaid program, so it's going to hold down costs. And so it would cut federal spending by $810 billion over 10 years. All right, and so the Urban Institute predicts that states would drop between 14 and 27 million from Medicaid rules by 2021 and cut reimbursements to providers by 31% under this particular block grant approach. So it does hold down costs, but it does so by covering fewer people and cutting reimbursements to providers. Okay, And also in terms of shifting control, they're going to limit federal standards and requirements on private insurance and Medicare coverage. So the belief is that there are too many rules on the market that are constraining things. For example, Mitt Romney opposes guaranteed issue, which is requiring that insurers accept all customers regardless of their health status and the pre-existing conditions. They oppose the Affordable Care Act requirement that health plans are created after 2010 must provide free preventive care for age-appropriate populations. So that was implemented under the ACA, these sort of free cholesterol tests, mammograms, and these other types of things. So that would be rolled back. What the Romney and Ryan would like to do is emphasize market competition, and you've heard the word voucher care, okay? So that's a main part of their platform. This doesn't affect you if you have Medicare now. It affects anyone who's eligible for the program after 2023. So if you're 55 now, age or under, you're going to be subject to this new plan. Age of eligibility would increase to, for Medicare would increase to 67 in 2033. And so what happens is Medicare beneficiaries are going to get voucher payments to purchase private health insurance, okay? And so they would choose amongst competing plans, again, on an exchange, a market set up by the government, in this case, probably by each individual state as well. Okay, so among those options would be the current Medicare fee-for-service program. So that stays under the Romney-Ryan proposal. But the amount of the voucher that each Medicare beneficiary is going to get is going to be based on the second least expensive plan on the exchange. So, you know, all the insurance companies are going to bid, all right? And so that Medicare program may be the least expensive, but it may not be. It certainly could end up being one of the more expensive. And so you take your voucher, and then you're allowed to supplement and pay for a more expensive plan with your own income. And then there is a notion that the vouchers would be adjusted for individuals' health status and income. And that's where the details are missing. I couldn't find any information on exactly how that adjustment would be made. Okay, a CBO analysis of this particular proposal claims that the average Medicare spending for new enrollees in 2050 would be between 35 and 45% below what it would be under the current program. Okay, and so what they're saying is, yes, we can control Medicare expenditures, but we're doing that by making seniors pay for more of the cost out of pocket, right? Sort of total costs of medical care aren't magically going to go down. It's a matter of shifting costs over to the Medicare beneficiary instead. Now, I will say this, I'm still, not that I got to spend, weeks and weeks analyzing this, I can't quite figure out how they got that number. If the Romney and Ryan said they would adjust this according to income and health care status, I was like, well, if you don't know what those adjustments to income and health care status are, how can you come up with the numbers? So there is some sort of misunderstanding, and this is why, again, uncertainty about these proposals and how they're going to affect expenditures. Okay, so there's higher out-of-pocket health care costs for seniors, that's for sure, we just don't know how much. There will be reduced access to health care. Because the plans may not be as generous as people are going to be able to afford. There is an assertion by the CBO that there will be diminished quality of care, but the increased competition should improve efficiency of healthcare delivery. With less expenditures, though, there's going to be less incentives for firms to develop new high-cost technologies, and that could be a problem. Okay? Another part of the Romney plan is to emphasize consumer choice, really get patients to be out there and be shoppers, okay? One way to do this is, not quite related, but a part of their platform is to allow the purchase of individual insurance to be tax deductible. Okay, so what I mean by that is currently, if you're self-employed, if you own your own business, you don't get the tax deduction, the tax exemption from income tax on your health insurance that anyone with employer-provided health insurance gets. Okay, so this particular policy would certainly allow those who are self-employed to buy more health insurance than they have now, and so that gives them more power in terms of choice. Although I would think almost every health economist I know would be against this, we actually don't want this exemption, and we want this exemption gradually removed for everybody with employer-provided health insurance, because we think it leads to a tendency to over-purchase on health insurance versus taking take-home wages. Okay, another thing they propose, and you've seen this in the McCain platform before, would be to allow consumers to purchase insurance across state lines. Currently, insurance does not work like that. It's regulated within each particular market. And one study I found here suggests that a national market for health insurance would reduce the number of uninsured by 8.2 million. So that's a significant number, and one that we should not take lightly. This study was written by Steve Parente, who's actually advising the Romney campaign, but I will also say that one of the co-authors is Gene Abraham, who served on the Council of Economic Advisors under President Obama at the start of his administration. So I think this is a balanced study. The reason I am suspicious of this study is actually just in terms of the economics. That simulation about the 8.2 million assumes that every state will keep the same insurance premiums after this regulation is introduced. I'm not so sure about that, because once you break down these markets, insurers get even bigger. They could have more market power, and as a result of that, actually raise their health insurance premiums, which makes it harder for people to afford coverage. So that's the only concern I have with that. And finally, allowing health savings account funds to be used for insurance premiums as part of Romney's platform. You'll actually see, you may not, some of you might have an HSA yourself, but there are only, I think, about 13% of all health insurance plans provided by employer-sponsored health insurance right now. But there's a study that came out that's saying enrolling 50% of workers in consumer-directed health plans could lower health spending by as much as $57 billion. So that's a nice chunk of change. It's actually 4% of total Medicare medical spending for people under 65 in this country right now. So that's a promising point. We are going to move towards more consumer-directed health plans, and the authors chose this 50% number because they actually thought it was a realistic number for us to reach over the next 10 years. So I think that sounds like a good policy proposal. Finally, you've heard about the notion that many in the Republican Party would like to repeal the Affordable Care Act. This study was just put out, and it is put out by the federal government, and it predicts the solvency of the Medicare Part A trust fund if we actually maintain the Affordable Care Act. The solvency of Medicare stays all the way out through 2024. Repealing the Affordable Care Act will actually make us go into deficit on the Part A trust fund earlier, okay? Because that's the cuts in Medicare that are in the Affordable Care Act, which are cuts to health care providers. They're not cuts to beneficiaries. But those cuts actually do a good job in terms of maintaining the solvency of the Part A trust fund for quite a few years to come. And I will leave it at that, and I will hand things over on the state side to Elena.
Okay, I'm going to bring it back home to Texas. When Vivian started, she explained that the real purpose of the Affordable Care Act is to expand insurance coverage, to reduce the number of uninsured people in this country. And one of the ways that will happen under the Affordable Care Act is if states opt into Medicaid, an expansion of Medicaid. The way the act was originally written, there was an automatic expansion of Medicaid. And one of the things the Supreme Court did in ruling on the case was rule that the states had the option of expanding Medicaid or not expanding Medicaid. So I'm going to take you through the analysis that the state of Texas will have to go through as it makes that decision for itself over the course of the next year. Okay, well, in Texas, what's the problem that a Medicaid expansion might have? Well, if you live here, you've heard for years and years and years how high our rate of uninsured is. We have 6 million people in the state who are uninsured. When they seek health care, they often do it in hospital emergency rooms because they can go there, and that means their care is largely unmanaged. They're getting wherever they can without somebody really supervising their care and helping them access the system appropriately. Texas providers, especially our hospitals, spend billions of dollars each year paying for the care of those uninsured people. And the cost of that care doesn't just go away, it's shifted. The hospitals have to make enough money to stay in business, and the way they cover those costs are in two ways. First, they shift some of those costs onto their paying customers, so that if you have your own health insurance through your employer or that you purchased on your own, a part of that premium is actually covering the cost of uninsured. And second, local taxpayers, those of us in Harris County through the Harris County Hospital District, pay each year a little over $500 million in Harris County to pay for the supportive services to the uninsured. And so that's why we ought to look at Medicaid expansion as a potential solution. Okay, this is the summary of everything I'm going to tell you tonight. I'm going to throw it up here very quickly, and then I'm going to go through the yeses and then the nos, and I will probably throw this one back up here at the end. First, let me talk a little bit about the current Texas Medicaid program. Medicaid is a huge program. It's very, very complicated, and people who spend their whole lives working in it still don't know everything about it. But to talk to you about who's in Medicaid today in Texas, this graph shows you who is covered under Texas Medicaid. The little red lines that are in the middle of some of the bars show you what the federal program requires. Medicaid, let me back up even another minute. Medicaid is a state-federal program. There's certain parameters, populations, and services that the federal government requires any state who is going to participate in Medicaid to use. And then above those benefits or above those population levels, the states can choose to increase their services and their population. And so what this shows is everything in blue is what Texas currently covers. This is by population. And the little red bars show you what's mandated and where Texas has opted to go beyond what is mandated. And these lines are all based on poverty levels. I don't know if you can see the categories or poverty levels out there. But basically, what this shows is that Medicaid pays for kids, for pregnant women, and for disabled people. Those are really the only populations that are covered by Medicaid today in Texas. Other states cover up to higher poverty levels in some categories, lower in some categories. And here's where the money really goes. So if you look at the caseload column, you'll see that the smallest amount are non-disabled adults. That's largely pregnant women. And then the biggest caseload, the most people who are on Medicaid, are non-disabled children. And that's because Texas does a good job of providing Medicaid to our kids who are in poor families. And then the top, the middle slab, which is on top, are aged and disabled people. But then if you look over at the cost, you see that the pregnant women, non-disabled adults use up about as much money as their population would argue for. You look at the kids, and the kids are relatively cheap to cover. Most kids, fortunately, are healthy, and so the costs associated with their care are not as great as their percentage participation in the program. But then where you really get into the big expenditures are the aged and disabled populations. A lot of this money goes to nursing homes, and a lot of it takes care of really sick people. But this is who is on Medicaid, and here's where the money goes. All right, so if Medicaid were to expand, the federal government says that it will expand to cover everyone up to 133% of the federal poverty level. And so what this means in Texas, largely when we talk about the Medicaid expansion, are really these two big red columns over here. And those are parents and then childless adults. The parents who get coverage right now, the little bitty blue sliver at the bottom of the parents column, is reserved for 5 years at the most for the parents of children who receive temporary assistance to needy families, what we used to call welfare. So very few parents today, unless they are pregnant or disabled, receive Medicaid. But under the expansion, you see that we would have a large population of adults who would become eligible. So in Texas, we think that about 1.7 million of the uninsured people would become eligible for the Medicaid expansion. And the reason for this is this pie chart breaks down all of the uninsured people in Texas, the 6 million of them. And the biggest slice over here are the people up to 133% of poverty. So this is the guts of the expansion population. And while it says 2.6 million up here, in part because some are undocumented, in part for other myriad reasons, the prediction is that probably 1.7 million people would be covered in Texas by the Medicaid expansion. Okay, so one reason that a lot of people are pushing the state of Texas to accept the opportunity to expand the program is because the bulk of the costs are paid for by the federal government. The current Medicaid program has various kinds of splits, but generally it's 60-40, 60% feds, 40% state dollars. The expansion requires that the federal government pay 100% of the costs for the new population for the first 3 years, and then a decreasing amount ending at 90% of the costs in 2020 and thereafter. The reason that you see that the total cost for the state would be higher than just their ultimately 10% is because there are additional costs that will come along with the Medicaid expansion. Two of the largest categories include what people call the welcome mat, or some people call the woodwork effect, which means that when you expand the Medicaid program, because of the publicity and all the hype around it, there are people who are eligible right now for Medicaid who will come out of the woodwork or come in on the welcome mat and will sign up for the program. And if somebody enrolls in Medicaid who is eligible today, the same rules apply in terms of their funding today. So the feds would be paying 60%, not the 100% or 90% that it would pay later on. The other part of the little hiccup for the state is that the Affordable Care Act is increasing payments to primary care providers, and that is because they are going to be the primary access point. They are among generally the lowest paid professionals, and this is an opportunity to give greater incentives for primary care. Okay. Another reason, and this is the reason that the hospitals are behind Medicaid expansion, is because there's a funding stream that's part of the current federal Medicaid program that is going to go away. And it's going to go away regardless of whether we expand Medicaid or not. And it's called Disproportionate Share Hospital, or DSH, and it's a complicated formula that someone from a hospital could probably explain to you. But it's a payment that goes to hospitals now when they serve a large number of uninsured people. And because the goal of the Affordable Care Act is to reduce the number of uninsured over the course of its lifetime, the DSH payments that come out of the Medicaid program right now are similarly going to reduce, the theory being these people are going to be insured, whether it's through Medicaid or otherwise, and so payments to cover them as uninsured will not be necessary anymore. And so the hospitals in Texas receive about $1 billion a year, and that's going to go away. And if this population, 1.7 million more people, become covered by Medicaid, there will be some payment for those people when they go to hospitals, as opposed to today when there's no payment and the hospitals end up getting some kind of payment from DSH. There's also the possibility that the Medicaid funds can replace some local taxpayer dollars. The Harris County Hospital District, whose budget is a little over $1 billion a year, spent more than half of its money, about $675 million in 2011, caring for the uninsured. And they see 300,000 or 350,000 patients a year. And it's estimated that about 100,000 of those patients could become or would become Medicaid eligible. And if they were Medicaid eligible, then instead of spending the county tax dollars on their care, the hospitals and doctors who see those patients would have a Medicaid payment. And lastly, a reason that public health advocates urge states to adopt the Medicaid expansion is because the more people who are insured, the more people who are in the healthcare system, the entire population benefits. It benefits in really simple ways. If you can imagine, you are around people all the time who are sick, and if they're not able to get to the doctor and get treatment, then you have the risk of contracting their communicable diseases. You also have productivity issues. When people are sick, they don't go to work and they don't go to school, and this would allow them to become more productive. So on the other side now, why should Texas think seriously about this opportunity to expand, and why should Texas perhaps reject it? First of all, it's not entirely free. It is $16 billion over the course of 10 years, and that's a number from the state. Its original projection was $27 billion. It's brought it down to $16 billion, and there's some people who think it may be less than that, but let's assume that it's that much. If you follow state politics or the state budget at all, then you know that we faced a huge deficit in the last biennium, and part of the way that was patched up was by deferring a lot of expenses into this biennium, including some Medicaid expenses. And so even though we have a stronger economy than we did in the last budget cycle and is projected to continue going forward, there's still old business to attend to. Also, there are many in Texas who would like to see the state reduce spending regardless of the amount of money that's available. And there are many who say that there are other pressing needs, particularly in the area of public education. Public education took a huge hit in the last budget cycle, and there are many who say that the first new dollars that go out to anything, to expand anything, are going to go to public education, and that Medicaid will be way at the back of the line. Some people also say Medicaid has grown too much and too quickly, and this gives you a chart going back to September of '79 to show you what has changed in the Medicaid program. You can see originally Medicaid, when it was put in place in the 60s, it was really to help aged and disabled adults and children who were poor. And then over time, the program expanded to include other populations. You can see that there was a big push to get more kids covered, and then there's a push to get pregnant women covered. And so a lot of people look at this as program creep and say an expansion of Medicaid is more program creep, and what will happen if we continue moving in that direction. And you can't ever look at Texas and Medicaid without looking at our population trends. One reason, and perhaps the largest reason, that our Medicaid costs in Texas continue to grow is because our population of people living in poverty continues to grow, and the growth of that population outstrips the rate of growth of the population as a whole. So we are growing more and more poor people in Texas, and that's why the Medicaid rolls keep increasing. More people are eligible. There are also problems with the Medicaid program. It's an old program, and as it's been changed over time, it sort of looks like a cobbled together program today. And there are many people on both sides of the aisle, and people who love Medicaid, who say that there need to be some changes in the programs, and why should we expand something that's not very good in the first place? And the kinds of things they talk about have to do with personal responsibility. If you think about your own private insurance plan, you probably pay a lot more if you go to the emergency room than if you go to your doctor's office for care, and that's to incent you to choose an appropriate level of care. Medicaid beneficiaries don't pay copays, and so the incentive for them to seek out care in a doctor's office, if it's easier to go to the ER, there's just not that incentive. There are also problems with some of the benefits. They haven't kept up with the changes in practices. The professional pediatric organizations, for example, have a template of well-child benefits that ought to be provided, and the CHIP program uses those benefits. But in the Medicaid program, we're still using an older set or older list of benefits. And then the last reason is one Vivian talked about, and that a lot of people think that the state should receive Medicaid funding as a block grant, and that the state should be able to do whatever they want with that money within the Medicaid program. And Vivian talked about one downside to that was that, the upside to that from the federal perspective is that over time, the cost to the federal government of Medicaid would go down. The downside to that for the state is when all of those people lose coverage because Medicaid shrinks, they live in the state, and so it's going to fall to state and local taxpayers to pick up that slack. And lastly, as a matter of public policy, some people do not believe that there should be government-sponsored health care for able-bodied adults. And that's a matter of public policy debate and a reason that a lot of people oppose the expansion of Medicaid. I'll leave you with a quote from Tom Cease, who is the recently retired head of the Texas Health and Human Services Commissioner, and a man who was actually admired by people from all walks of life and on all ends of the Medicaid and Texas healthcare spectrum. But what he says is, we're not debating whether somebody gets health care in this state. We're debating how you pay for it. And either you're going to pay for it through the Medicaid program, or you're going to pay for it through private insurance, through subsidies, or you're going to pay for it through local tax dollars. And those are the choices that Texas will be making. I'll throw up the summary slide and then turn it back over to Dr. Mendelson. Thank you.
Well, good evening. It's terrific to see this huge turnout on a subject that I think all of us are very worried about. It's about 18% of the GDP right now, and I think we're all going to suffer tremendously if we don't address these questions. I'm going to make two comments, and I'm going to open to questions. My first comment is that I've read and heard a lot about this area, and I don't think you'll ever hear two better evidence-based presentations on the pros and cons of the issues. So thank you. And the other thing I'll say is that I agree with what Vivian said. The key issue that all of us are facing isn't what we were hearing about. Those are important issues. The key issue is how to convert payment for health care so that we no longer pay for all services one by one, but we have another payment system that pays for value and it pays for outcomes. And none of this past 45 minutes has addressed that because it's not on the agenda of the politicians right now. But regardless of how we pay for the health care, we're going to have how we pay for the distribution of reimbursements and to take care of Medicaid, Medicare, children, and everybody. We've got to figure out a way to change the whole reimbursement system, and we haven't addressed that properly. Although the ACA bill does have pilot projects and talks about this among its 2,700 pages, which I've not read. Let's invite questions. There's two microphones on the aisle here. And please vent and please ask questions. I can ask some questions, but I'd much rather hear yours, and we would.
Under the Ryan
Why don't you
voucher,
introduce your name briefly and what you do?
I'm Doug Koch. I'm an ophthalmologist at Baylor.
Great.
Very much enjoyed your presentations. Thank you. Under the Ryan voucher plan, where folks would be reimbursed at the second lowest cost of the vouchers, is there some threshold of healthcare delivery for those plans so that, an insurance company can offer a totally inadequate plan that would be very inexpensive, and then that way folks would get, very low reimbursement from Medicare to purchase these plans? And so I just wondered what they say about that.
Oh, that's a very good question, and I'm not sure that has been, level of detail is not available on the Romney website. My guess is, though, with his particular advisors, that they would specify a particular range of services that would have to be covered by all healthcare plans, because there's a fair amount of research showing that if you didn't do that, the amount of confusion in terms of both price and the range of services would be so difficult for consumers to digest that you would certainly end up with an inefficient outcome. So I think there would be some room, but yeah, no, we don't want to. Yeah, I don't think they're going to be offering sort of rock bottom in terms of quality policies on that plan.
We hope there's going to be competition that'll provide services because people can make a choice. We hope. Yes.
Hi, Ken Yonda with Community Health Choice. Both of these ladies know me very well, but as somebody that lives and works in the Medicaid space every day at Community Health Choice, I'll definitely second what Elena says, that all of us that work in the Medicaid space believe there needs to be real changes in the program in terms of benefits and co-payments and those kind of things. But I guess this question is really for Vivian in terms of what a President Romney would do. If you take Elena's numbers and say there's roughly 2 million people or so in Texas that are uninsured below 133% of the federal poverty level. I just changed it from 2.6 to 2 million, but saying the rest of those are undocumented and we just are going to pretend they don't exist. But the other 2 million people, what I struggle with is, what would you do as President Romney? My understanding is you would repeal the Affordable Care Act. So that means you wouldn't provide that extra funds to the state of Texas. People below 133% of the federal poverty level are not going to buy commercial health insurance. If I could figure out a way to do that, I would sell them a program, but they don't have the funds to do that. You know, right now, I think basically what the policy or the proposal would be that Texas should continue and expand paying for that care with local tax dollars and expand the hospital district and do that? Or is there something in any of his proposals that actually talks about an alternative to the Medicaid expansion for low-income people?
No, is the short answer. I think the way the CBO has done the analysis is when you move towards repealing the Affordable Care Act, and you take the Ryan Romney plan of moving to block grants, you will undoubtedly save money, and you will undoubtedly save money by cutting people off the Medicaid rolls. And as Elena said, there's this claim that there's inefficiencies in the system and there's waste, and if magically if you just sort of handed this all over to the state could fix the problem. I actually think the people in our state health department are pretty intelligent, and they've tried everything they can do. They're just dealing with a very limited amount of money. Now, that being said, the ambassador started this off, the whole talk, that in ways we're sort of, we're just ending the silly season of this particular campaign, and you can go with the campaign rhetoric, but on the other hand, I think it would be very interesting to see how Romney would behave if he actually were president and he weren't beholden to, for example, people in the Tea Party, and it depends on what would be the mix of Congress, sort of who controls the House and the Senate, because his main health advisor is Michael Levitt, who's actually quite a moderate healthcare policymaker and is in favor of creating health insurance exchanges in the Affordable Care Act and is urging states to do so. So there's a question of how much of this is politics that appeals to the media and how much is, would he actually do this? And once he realizes, everyone says, oh goodness, this is actually what's going to happen to our Medicaid population, and this is what's going to happen to our hospitals, and then, sort of this is what's going to happen to our local health insurance rates and things.
Thanks.
Ron Cookston with Gateway to Care. Being in a place with such brilliant people causes me to want to ask this question. I understand I can do the arithmetic and I can get to the $16 billion cost over 10 years with the Medicaid expansion. I can follow that arithmetic. What I don't follow, however, is, and I don't have any idea how to understand it, is the arithmetic associated with all those billions of dollars that we as taxpayers of the state of Texas are sending to the federal government that are going to come back into the state of Texas, and how they would roll through our economy, because after all, our economy and our taxes are paid under sales taxes and so forth. I can understand how you get to the 16 billion, but isn't just the sales tax revenue alone going to offset that or make it a positive for the state of Texas?
I don't think the sales tax alone will do that, but there are all sorts of theories and economic multipliers out there that talk about the $116 billion, the 100 from the feds and the 16 from the state over 10 years, and the effect that would have. Those dollars would be spent on the healthcare workforce, and so they would go into the paychecks of people, and they would go toward building new buildings and purchasing more drugs and equipment, and that would have a multiplier effect in the economy. I think somebody will do some actual numbers attached to that, but I didn't.
Maybe one of y'all might do that.
Thank you. My name is Dr. Margaret Nosek with the Department of Physical Medicine and Rehabilitation at Baylor College of Medicine. And first, I'd like to compliment you on the clarity of your presentations. Thank you. I strive to achieve that with my students, several of whom are here tonight. I appreciate the role model. My question has to do with two other political trends, and I'd like to ask you for your comments. And that has to do first with nursing homes, and second with care for low-income pregnant women or women who could be pregnant. The chart that you had up there about the largest bar on the bar graph in Medicaid spending in Texas goes to nursing homes. And it's become a very political issue within a movement that I'm active in, which is the disability rights movement, about the Olmstead decision and the right of people with disabilities, including people who are aged and as a result of disability have to live in a nursing home, to live in their own homes. And that's become very politicized. So how in this environment in Texas could the change of an administration in Washington or in Texas potentially affect the implementation of the Olmstead decision and the Medicaid spending on nursing homes in the state of Texas? The other area is about the political decisions that were made about spending toward Planned Parenthood and women's services that it offers to very low-income women. How do you view the impact of that on the expenditures in terms of Medicaid dollars, or how that's going to impact the state economy and particularly for low-income women? Thank you.
Do you want to?
You want to talk about nursing homes, or do you want me to talk about nursing homes?
Why don't let me hear what you have to say about nursing homes.
Okay. I'm not sure where you're going with the question about nursing homes. And I frankly am not that familiar with that part of the Medicaid program, other than to know that it's very expensive. And I know that there is a movement to allow people to stay in their own homes and to make more choices about where they might spend their time and not necessarily be in nursing homes, and and a lot of those programs have cost savings attached to them, because if you're not in a nursing home, they're generally lower cost settings. And how you make that change, either through the legislature or through HHSC, I'm not sure. The legislature seems to respond in most cases, but your second question would belie this, to economic arguments, where if you can show that people are better off and it costs less, they tend to respond to that in some cases.
Yeah, I'll just add to that. dealing with nursing with people who need nursing home care and the notion of getting them into the home, there's no doubt that would lead to higher satisfaction amongst those groups of beneficiaries. But the problem health economists are struggling with is every time you introduce that home option, you get more beneficiaries who come out of the woodwork and say, well, I never would have wanted to be in a nursing home, but I certainly would like to have some coverage for my home care. And so that's a problem. It's a question we're still struggling with, and we haven't been able to solve, and it's going to be with us for a while. You know, I think it's going to be a challenging question under both administrations. There'll be less money for Medicaid under a Romney plan, but it's certainly a challenge, and certainly we see that now. All the states, in terms of when there are cuts in terms of budget shortfalls, where do they cut first? They cut in Medicaid and they cut in the elderly in Medicaid, and it's unfortunate. And I'm going to leave the issue of talking about the state's coverage decisions and Planned Parenthood and that to the expert.
Well, that would belie then the economic argument. Two things happened regarding women's health. One had to do with the basic family planning funding that has been in place in the state. It's all federal pass-through dollars. And in the last go-round, there was about $112 million, and they cut that down to $39 million. And that money is used to pay for well woman exams and birth control for women at, I want to say, up to 185% of poverty, poor women. Then there is also the Women's Health Program, which was a separate program that covered under Medicaid any woman up to 185% of poverty who might have become pregnant. And the theory was that if you provided a woman birth control in place of waiting for her to become pregnant, then the state would save a lot of money, because the cost of providing birth control is cheaper than the cost of providing the prenatal care and then presumably covering the life of the child that would be born. So both of those things happened in the last legislative session, and the Legislative Budget Board, which is like the Congressional Budget Office, it's a nonpartisan think tank, if you will, that analyzes state budget decisions and analyzes all bills based on their impact on the state budget, concluded that in both cases the state was going to incur extremely high costs as a result of discontinuing those programs. But for political reasons, the state reduced family planning down to $39 million for the entire state, and is now going to lose the 90% match in federal funding that paid for birth control for low-income women, because the state has chosen to exclude Planned Parenthood as a provider, and federal law requires that any qualified provider, regardless of whether they are affiliated with abortion providers, must be included in the Medicaid program if patients choose to go there. So bad for women, bad for the state budget.
Pretty devastating. Just to add to the fears, I've seen estimates as high as 40% of us are going to get Alzheimer's if we live beyond age 85. And Alzheimer's patients live a long time. And if you think about that impact on nursing homes, as we get to be more and more of the healthcare in this country, although it's belittled, is pretty good for most of us. And we are living longer. I see that because we see a lot more cancer. That's increasing. But it's Alzheimer's that scares me. And the brain degenerative diseases, Parkinsonism, there's more of it now than there was. And these people either have to go live with their kids, or they got to go to a nursing home. And I'm watching my kids, and you're watching your kids, and their kids, the grandkids, are needing help to age 25 or 30 now. And then, meanwhile, their parents are needing more help. And we're suddenly going to be depending on an age group of about 25 to 65 to support over half this population, the young kids and the old kids. And we've got to we've got to change how we pay for health care. We just got to. More questions? Yes, someone's coming up here.
Chuck Begley, UT School of Public Health. I was speaking, my question addresses, I think, to some extent, Dr. Mendelson, your comment about what we really need is a new way of paying for our healthcare services and figure out new ways of delivering healthcare services. And I just wanted to ask, I think, Vivian, her opinion. I know that indeed that the ACA, the major provisions of ACA do deal primarily with coverage, but there are, and the offsetting cost saving from just paying Medicare providers less in the out years is the major cost containment provision. But there are also a series of initiatives and pilot studies and demonstration projects dealing with things like accountable care organization, bundled payment experiments, pay for performance kinds of things. And I just wondered if you had any perspective on whether you think what's in the Affordable Care Act in that regard has any significant potential for bending the cost curve and actually delivering in terms of transforming our healthcare system.
Chuck, thanks very much for asking that question. So as Dr. Mendelson said, there's a portion of the Affordable Care Act that just is not in the media, and I think it frustrates both of us greatly. Because, and I just don't understand why the public isn't more angry at the healthcare system for making them overpay for their healthcare. And so the notion that sounds really good on paper is, instead of just paying piecemeal, pay the physician one reimbursement rate, pay the doctor another reimbursement rate, and actually incentives actually go against each other. The hospitals under Medicare have an incentive to get you out as fast as possible, and the physicians have an incentive to keep you in as long as possible and give you as many tests as possible, because that's how they'll make more money. And so the notion is that we should pay, for example, a bundled payment. One payment that goes to the hospital and the physicians who took care of the patients. They're going to have to split up that particular amount of money, and it's going to vary according to, it's a fixed payment, but there will also be adjustments. We're going to monitor the quality and sort of see, do you actually get the patient out in a timely manner with no quick readmissions, no infection rates, none of this, other stuff that don't leave surgical devices left in you after you've had your operation. Because certain, just up until 2 or 3 years ago, you actually got rewarded more when from Medicare if you did that, because that's the way the reimbursements were set up. So the Affordable Care Act sets up these experiments, as Dr. Begley at UT referred to, in terms of these bundled payments and accountable care organizations that require more integrated care. It sounds wonderful on paper, and I do have the belief that in the long run it's going to work, but it's just going to take time, simply because most physicians are horrible managers, all right? They went to medical school, they didn't get an MBA. And so the initial results that are coming out from the demonstration projects, the very first results were, oh gosh, we tried this and it doesn't save money. Now we're starting to see more improvements. So there are a larger proportion of groups where this has been applied to and it's working, but there are small cost savings. It's just going to take time, because we have to get doctors and hospitals to start thinking in terms of providing efficiency instead of just cranking out dollars and getting patients through the door. So it's sort of this tough issue, but I think it will work. So I'm optimistic about it. It's just, don't expect it to happen next year.
When we have some opportunity to experiment with that in Medicaid in Texas, because it's all in managed care. And if you run a company like Ken's, then you have the opportunity to work with your providers so that you are rewarding them for quality of care and not quantity of care. And it's seeing some success.
Good. Well, while you're thinking, maybe I'll ask a question. Oh, good, here comes one.
Enjoyed your presentation, fantastic. I'm Carla Tyson Howard, Health Information Technology Program at Houston Community College, and we brought a whole lot of our students.
Oh, great.
But my question to you is, can you explain Mitt Romney's plan, his plan for Massachusetts, and how that compares to Obamacare?
Oh.
Great question. And can you tell us, is it going to cost more or is it going to save money?
Okay, so the economists are just starting to work through the data. Thank you for asking that question. I can't answer it completely because we still don't quite know the full answer. It's certainly worked in terms of health insurance coverage. So there, the Massachusetts now has the lowest percentage of uninsured in the entire country. In terms of healthcare expenditures, my understanding is that healthcare expenditures have continued to grow, but they have grown at a slower rate than the rest of the country. And there are also some interesting sort of findings that people are discovering. For example, the reimbursement rates for hospitals, the average reimbursement rate per patient is declining, and they think that's because what happens is you sort of got some of these people who were sort of lower risk without health insurance. You got these people, and actually, this factors in people who didn't use hospital care at all. This is average reimbursement for hospital care across the whole state. So the reimbursement rates declined because you got all these healthy people. You made them buy health insurance, all right? And so they were in there, they didn't use hospital care, and that lowered premiums for everyone else. Okay, so this does lead to a cost to people who are very healthy and don't incur any healthcare expenses, but it leads to it leads to lower costs for other people. That being said, I think we should be careful about saying whether, it works so well for Massachusetts, it's going to work for the rest of us. Massachusetts is a very small state. The 6 million people we have uninsured here it's larger than the entire population of Massachusetts. So there were sort of efforts that there were social workers who got out their laptops and enrolled everybody who showed up in an emergency room there in Medicaid insurance or whatever insurance they needed. I don't think we can afford to do that here in Texas. We just don't have the money. So it's not as if we're going to be able to sort of suddenly give health insurance to these 6 million people. It's not that easy, and I think we're going to have a lot of problems. And as someone already mentioned, I think Ken already mentioned, we've got the sort of illegal immigrants who will not benefit from the Affordable Care Act, but they're still showing up for health care here. So I don't think we can sort of conclude that the rosy picture for Massachusetts is going to be that it's going to be a rosy picture for Texas, and that's what I'm worried about.
We can add that even before the Romney Care in Massachusetts, they had the lowest number of uninsured people too. I think it was 6% in Massachusetts. It's 25% in Texas, and it's 30% in Houston. Almost 1 out of 3 people in our community are uninsured. And to enroll all of them in this program, it's going to affect our wallets. On the other hand, to not enroll them is affecting our wallets too. And there are drive-bys at our emergency rooms because they're filled with these people that come in with colds and fevers, and the car wrecks have to go for miles because the emergency room is full. So again, we've got to change the system. I'm going to ask about NICE. Now, the British have a system. They have a panel of experts that vets all new technologies and drugs and procedures, and they draw the line. And I'll just give you one example of that that's cynical. When I was working in California at a previous job, the state of Oregon set up a panel that would decide what would be paid for and what wouldn't be, and they listed everything, and they drew a line when they ran out of money. And renal dialysis fell below the line. And everybody in Oregon that had renal failure moved to Texas quickly. Moved to California quickly, because they were not going to be able to get any state aid in taking care of their dialysis. And that's just how poignant it can get. But the thing we hear about is we don't want grandma to be told what to do the way they're doing it in England. But if you're grandma in 1/3 of the families in this community, you're told what to do. It's by fiat. It's not by a committee of intelligent people. And I'm very curious about what you think about this. I forget the 4-letter term for this committee that was supposed to be set up to do this kind of thing for our country. And of course, it's never been set up because so many people don't want the government telling us what to do about grandma. And how do you feel about that?
Yeah, okay, so I can't remember what NICE stands for. This is an organization in the UK.
I can't remember what it stands for. They have 4 letters instead of 3, but it's a terminology that says we're going to decide what's going to be reimbursed and what isn't in England.
Right. Thanks. And so what?
Britain.
Right. And so if there are certain technologies that they decide that the cost per unit of benefit is too expensive, you don't get it. You could pay for it for yourself out of pocket if you wanted to, but their national healthcare system isn't going to pay that. I personally, what I would like to see, and I've asked Alan Garber, who was a major advisor for the Center for Medicare and Medicaid Services. He's a health economist. He's now provost at Harvard. And I said, I'd like something like that, but with an American flavor. What I'd like to be able to go out and buy an insurance policy which will cover everything, every intervention where it's been shown that cost per year of life saved is $100,000 per year of life saved or less. Or you could even make it $200,000 per year of life saved. So cover all those technologies that we know that for. And it'll actually cut out a lot of waste, so my premium will be lower. So give that to me because I'll get the most cost-effective care and I'll be able to get a lower health insurance premium because of it. He goes, no, it'll never work. And he kind of dismissed it because somehow there's I don't know if you agree with this, but there's a different psyche in terms of what Americans are willing to hand over to the government versus what people in the UK are willing to allow a federal organization to decide.
Well, I think there is a difference. I think certainly when I see in the cancer field, most of us feel when we're with our families and our friends in our community that if someone has a terribly challenging medical problem, if there's one chance in 100 or 200 that this could be solved, let's let that patient have a crack at it. And essentially what NICE is doing is a mental calculation, or actually a real yellow pad calculation, and they're saying if the possible benefit is so low, and our budget is only going to be 8% of the GDP, and that's what they've decided, we're going to have to say no to these people unless they pay privately. And the British people have accepted that. I have grandchildren living there. I was in Great Britain one October when the Secretary of Health, I forget what they call it there, went on television and announced that the health service had run out of money. And between then and December 31st, they would only pay for emergency care. And I'm sitting there thinking, well, what happens if my granddaughter gets an earache? Suddenly, the health service is no longer going to cover that for the next 2 months. And this was unbelievable. And the Brits accepted that. There would have been a revolution here.
Yeah.
You just can't do that in the United States. So there are different cultures.
NICE is National Institute for Health and Clinical Excellence.
National Institute for Health and Clinical Excellence is NICE. And incidentally, I think it has very good people on it, and they are very data-driven. And the calculation is what Vivian referred to, the cost per year of quality life, $50,000 or $100,000 per year of quality life. If you have a recurrence of leukemia, it's going to cost you much more than that. And the chance of getting a year of quality life is very low, but we're treating a lot of those. More questions? Here comes one.
Hi, my name is Masood Atik. I'm just a Rice freshman, which is still
Just.
something. My question is, I guess, more directed to Ms. Vivian Ho about your presentation on Romney's voucher care. As addressed before, like it's kind of, I guess, not really detailed in its planning. And with you saying like Obamacare kind of like showing some improvement in the way things are going, or like it has a good projection for where it's going. Do you think that presidential candidate Mitt Romney will kind of like set in stone the exact details of his idea for healthcare, or like not, like before the election? Will he set it in stone or not? Or do you think he has to in order to get support from that?
He will never be as clear as more than 2,000 pages of the Affordable Care Act, but he will be forced to be clearer once the debates start, because I'm sure there will be questions during the debates that are that are going to arise about healthcare and what he intends. But again, it's really hard to expect a candidate who doesn't have the full backing of, the federal government to, punch all these numbers and do all these calculations. So what he is, what he has to worry about is he thinks he wants to do a particular policy, and then he gets out there and says, well, this is what I want, and then, sort of left-leaning think tanks then are able to sort of pull up their models and be able to slant things against him. So I understand if he's gonna be vague on that for those particular reasons.
I'd just like to thank you for the whole presentation, both of y'all.
It
Thank you for
is
that.
7:30 and people do want to go to dinner, so let's thank our two experts. And thank you.
You want a picture of us? Should we be standing?